The renal system. We're going to start with the normal anatomy and physiology, just a brief review. The kidneys receive between 20 and 25% of cardiac output. And there's a box on page 767 that discusses the different sites of tubular reabsorption and secretion. You might want to review that. The entire blood volume travels through the kidneys 60 to 70 times a day. That's about 180 liters. That 180 liters a day gives us a glomerular filtration rate of 125 milliliters per minute. That's 1,200 milliliters per minute to the kidneys that go through. Filtrate, on the average, the amount of urinary output, in other words, that we have, is between 1 and 2 liters a day. The nervous supply to the kidneys, the central nervous system, autonomic nervous system portion of it, provides stretch receptors that send a message to the spinal cord. The bladder's getting full. Your peripheral nervous system contracts the detrusor muscle and relaxes the external sphincter. The cerebral cortex controls your micturition reflex, your frequency, your external sphincter tone, and your conscious control of urination. Urine is made in the glomerulus, and we measure our GFR, by checking the creatinine levels. In order to have an appropriate glomerular filtration rate, you need to have a constant arterial blood pressure. As long as your mean arterial pressure is anywhere from 80 to 180, that will work appropriately. Our normal creatinine clearance is 125 milliliters per minute. Therefore, our glomerular filtration rate is also 125 milliliters per minute. An increased pressure in the glomerulus from sediment will decrease filtration. A decrease in your onconic pressure will decrease the amount of filtrate. If your creatinine clearance is less than 100, your GFR is less than 100, and that means you have renal insufficiency. If your creatinine clearance is less than 20, you have renal failure. Tubular reabsorption is done by osmosis, diffusion, or active transport. Tubular secretion is by diffusion and active transport. And different substances have different levels that they must reach before they are excreted. For example, glucose's threshold is around 180. The older textbook said it was around 200. So they're saying the kidneys are a little bit more specific. Kidneys work to eliminate waste. Urea, uric acid, creatinine, bilirubin, ammonium chloride, and drug metabolates are all waste products. Your creatinine is the end product of your protein metabolism. The kidneys help to function to maintain your blood pressure regulation. You have your juxtaglomerular apparatus, or JG apparatus, and the distal convoluted tubules that synthesize, store, and release renin. Renin release occurs due to a decrease in blood volume, blood pressure, or the amount of sodium. Causes vasoconstriction and causes the conversion of angiotensin I to angiotensin II in the lungs. Angiotensin II then goes back to the adrenal medulla and causes a release of aldosterone, where aldosterone saves sodium and water. And the renin-angiotensin-aldosterone system is shown in a figure on page 769. The kidneys are also responsible for red blood cell production due to release of the erythropoietin, which is a hormone that is active for 24 hours. It goes to the bone marrow to increase red blood cell count production. It is released if we have a low red blood cell count or if we have a decrease in our oxygen level. Say you decide to climb Pikes Peak, among other places. The kidneys activate vitamin D, and vitamin D is necessary for us to absorb calcium. So if we don't have enough active vitamin D, we can end up with osteoporosis. Prostaglandin synthesis occurs in the kidney, and this is a very potent vasodilator. But this prostaglandin works only in the kidney. And it does this to maintain the GFR by causing an increase in sodium and water excretion, vasodilatation, and renin release. There's a box on page 770 that shows the effects of prostaglandins, because elsewhere in the body, prostaglandins cause pain. The kidneys are responsible for maintaining acid-base balance. Acid-base is slowly adjusted as hydrogen ions are excreted and chloride and bicarb are saved. So changes here take hours to days, where changes in the respiratory system, as we know, because we already had that, takes just a few minutes. It helps to maintain our fluid balance. There's a figure on page 771 that talks about our fluid balance. Males are 60% of their body is water. Females, 50% are water, because we tend to have a little bit more body fat. 77% of the infant is water, and 50% of the elderly is water. There are, as I said, figures on page 771 that talk about fluid balance. And there's another table on page 772 that discusses factors that stimulate the release of your antidiuretic hormone, aldosterone, and your atrial natriuretic factor, or peptide, ANP. The kidneys also help to maintain your electrolyte balance, and there are boxes on page 773 to 775 that discuss the function of your various electrolytes, which I'm sure, since you started that way back in 123, you will already know. But in case, these are the norms that are given by your textbook. They'll vary a little bit from hospital to hospital. Some hospitals say potassium of 5 is still normal. I don't know of any hospital that says potassium of less than 3.5 is normal, but you'll want to know your institution's norms. Your fluid balance is measured by your osmolality. Your normal osmolality is 275 to 295 milliosmoles per kilogram. You can estimate this level by the following formula. You take your serum sodium and multiply it by 2, and then you add your BUN. If it is increased, it's a dilutional effect or a decrease in your hemoglobin. ADH, your antidiuretic hormone, is secreted by the posterior pituitary, and it controls your extracellular fluid volume. There's a box on 772 that talks about it. Remember, ADH is released if you are hypernatremic, hypovolemic, under severe stress, have a temperature, and certain medications can cause ADH to be secreted, such as your narcotics, antineoplastics, your sulfonylureas, and your beta-adrenergic agents. Now, I know you all know your sulfonylureas are your oral diabetic medications, but just in case, I'll mention that. Aldosterone is released if you're hypovolemic, hyponatremic, or hyperkalemic, or under stress. And again, aldosterone saves sodium and water. ANF, or ANP, your atrial natriuretic factor, or your atrial natriuretic peptide, was found in the atrial cells of the heart, and they are released in response to hypernatremia, hypervolemia, vasoconstriction, or decreased cardiac output to increase urinary output. And then they found another one called BNP, and they thought that was from the brain. Turns out it's from the ventricles. But hypertension, increased systemic vascular resistance, cause ADH and aldosterone blockage, which results in vasodilatation, increased sodium and water output. Now, when you assess the renal system, the history you're going to get is on page 778 in your textbook. All the questions you're going to ask there. You're going to inspect the patient for any problems. Do they have jugular vein distension? Are their hand veins distended? And a good way to tell this is you put your hand veins down for 5 seconds, and if they don't fill, they're dehydrated. If when you raise the hand up, it takes more than 5 seconds for those veins to deflate, they have hypervolemia. You need to check for any bruising in the flank area, because that could indicate kidney problems. Are their mucous membranes moist or dry? Do they have any edema? There's a table on 779 that shows that talks about edema, and any edema that lasts less than 15 seconds is considered non-pitting. Remember, edema shows up after you've gained 10 pounds of weight, or 10% of your base weight is gained. So fluid volume excess, looking for edema or crackles is not the best system. What you want to do is a daily weight, because that will show the fluid gain before you start to get the edema or the crackles. Auscultation, you auscultate for your renal artery stenosis. Remember, your renal artery is to the left and right of the umbilicus. And if you hear a bruit, it means you have stenosis, because a bruit indicates turbulent blood flow. You want to listen to your heart sounds for any extra heart sounds. If you hear a rub, it could be from uremia. If you hear an S3 or S4, it means you have a fluid volume excess. You want to check your blood pressure, because that also helps to talk about hydration status. If you develop orthostatic hypotension, that means when you stand up, your blood pressure decreases by 20 millimeters. Or orthostatic tachycardia, that means your heart rate increases by 20 beats. Those are indications that you don't have enough fluid and the body's trying to maintain status. Your lung sounds you need to listen to, of course, to hear whether or not you hear crackles or what's going on. Now, palpation, you can only do that of the right kidney because the left is hidden by the ribs, so you can't really get at that. But the right you can. And there's a picture of how to do that on page 780. Percussion, you do with the heel of your hand or a fist, and so that you hear a thud when it hits the area. And you're checking to see also if your patient, if that elicits pain in your patient, maybe if they've had trauma there, or if they have a urinary tract infection. And you want to check for ascites, again, for fluid volume overload. With your fluid and electrolyte status, as I've mentioned, it's really important that you do a daily weight. Remember that 1 liter of fluid weighs 2.2 pounds. And therefore, you need to notify the physician if you gain more than 2 pounds per day of weight, unless it's that time of the month, ladies, because I could gain 10 pounds overnight. And it had nothing to do with increased intake. Intake and output is important, but you need to remember that you can have insensible fluid loss due to fever. For every degree Fahrenheit of temperature you have, you lose an additional 75 milliliters of fluid. You need to check your hemodynamic factors, and they're on page 781, and your electrolytes on page 782. Your lab values, your BUN. Now your book says 8 to 20. But the average in most institutions is 10 to 20. Your creatinine 0.7 to 1.5 milligrams per deciliter. And your BUN to creatinine ratio should be a ratio of 10 to 1. If it is less than that, it is prerenal failure. And if it's greater than that, it's intrarenal renal failure. Your urine osmolality. Normal is 275 to 295, and that will be increased with a decreased urinary output. And it'll be decreased with diuresis. So it's increased with a decrease in output and decreased with an increase in output. Your anion gap is what you can use to identify acidosis or alkalosis without your arterial blood gases, but it only looks at the metabolic piece. If it is greater than 14, you're in metabolic acidosis. If it's less than 11, you're in metabolic alkalosis. And you get your anion gap by taking your sodium, subtracting your chloride, and adding your bicarb to that from your electrolytes. Cystatin C is a substance that's synthesized and released by most of our cells at a constant rate. Now, this is something that it just was not in your last edition of this textbook. It's just in this one. The glomerulus filtrates cystatin C and the tubules metabolize it, so there are very low levels in the urine normally. In dysfunction, there's a decrease in filtration, so there's less that goes to the tubules, so there'll be more in the urine. These changes are seen earlier than in changes in your creatinine. Since they just started talking about this, this is not being used that whole lot yet, but it's something you may be seeing in the future. And you need to know your hemoglobin. For female, 12 to 16. For the male, 13.5 to 17.5. And I've seen some go all the way up to 18. And your hemoglobin and hematocrit should have a ratio of 1 to 3. Your albumin is 3.5 to 5.5 grams per deciliter, and your albumin is about 50% of the total protein in your body. And remember, your albumin is what binds to your drugs and transports them to where they need to go. Your urinalysis, there's a table on page 786, but your normal pH of your urine is between 4.5 to 8, so the average is around 6. The specific gravity is 1.010 to 1.020 as the usual. If it is less than 1.003, it is diluted, and if it's greater than 1.030, it's very concentrated. Glucose should only show up in the urine if your blood sugar is higher than 180. Protein should only be there in very small amounts, like 30 to 150 milligrams in a 24-hour time frame. Trace on a spot urinalysis. Even if you're on the Atkins diet, where it's a total high-protein diet, you should only have small amounts of protein in your urine. If you have more than that, you have damage to the basement membrane and you have renal failure. Your electrolytes, your spot sodium is the one that's done most often, and the normal is 40 to 220 milliequivalents per 24-hour time frame. Sediment, normally there's none. And to see if there's any sediment, you have to check that specimen within 30 minutes to be valid, because casts start to dissolve and your cells start to lyse after that length of time. So if you do a urinalysis and let it sit, you're never really going to see if there's any sediment. Hematuria, a rare red blood cell is okay, but otherwise it becomes a problem. Your spot urine sodium, that can also be done where you just get a random sample. If you have less than 10 milliequivalents per liter of sodium urine pre-renal failure, if you have more than 40, with an elevated creatinine, you have intrarenal renal failure. You can also do KUB, which is kidney, ureters, and bladder. You can do an IVP, intravenous pyelogram, which is to look at because you inject a dye, so it's the flow to the kidneys. It helps to identify if you have renal stenosis. That should be a capital T because it's a CT scan of the kidneys. Looks at the structures. Ultrasound of the kidney can be done. Magnetic resonance imaging. Angiogram, again, look at the blood supply, or biopsy. And that finishes this section, I believe.